Hello, ladies and gentlemen. Welcome to Has 20 Virtual Summit Breakouts. During this session, you'll be able to submit questions and upvote questions from other attendees. The questions with the most votes will most likely be among the questions asked by the host to the presenter at the end of the session during the live Q&A. The bottom right tile box is where you can type in your question as well as click the thumbs up button to upvote a question. During the session on the top right tile box, you will also see a 5-question quiz based on the speaker's content. Enhance your learning by taking the quiz during the session and get points for your correct answers. All sessions will be available on demand, and if the presenter has given us permission, you will also be able to download the slides. It is now my pleasure to introduce Session 9, Addressing Health Equity in the New Normal. This will be presented by Vivian Anugwam, Health Equity Manager, Allina Health. Enjoy the session.
I will start with just running through what the learning objectives are for this presentation, and then we'll talk about what is Allina's strategy for eliminating health disparities. And then I'll share an example of how we've used data analytics to support eliminating health disparities within our system, and then just show you some preliminary results to date for one of our projects. So I hope that by the end of this presentation, you'll understand how Allina Health uses data to identify disparities. And then I also hope to take some time to define what implicit bias is and its impact on health disparities. So a little bit about Allina Health. Allina Health is a not-for-profit healthcare system in Minnesota that cares for patients from beginning to end of life through our 90-plus clinics, 12 hospitals, and various specialty care services. Our mission is to prevent illness, restore health, and provide comfort to all who trust us with their care. This graphic here gives you a snapshot of all the different connections that we make, or we can make in a year, and really it shows how many opportunities we have to connect with our patients and ensure that we are providing care the way that they want. So anytime I'm talking about health equity, I always like to sort of set the stage with this graphic, and a lot of you probably have seen it, but it's a really good graphic that really shows the difference between equality and equity. So let's use a relevant example with COVID testing. So at the top, from an equality perspective, you see that every individual has, say, received a bike to get from home to a COVID testing site in their neighborhood. So we've given all of them the same bike. So that, that's right there is sort of an example or a depiction of what equality looks like. But from an equity perspective, and if you look below, you see that each individual was given a different bike. It gets at their specific needs and unique needs. So when we talk about equity, health equity, it's really about ensuring that we tailor the care that we provide to the communities and the patients that we serve to ensure that we are caring for them the way that they want to be cared for. So, a lot of us have probably heard a lot about COVID-19 and health disparities that are being magnified by COVID-19. Health disparities have always existed. There's no surprise that we're seeing communities of color being disproportionately affected by COVID-19. This pandemic has only magnified the disparities, and we need immediate and long-term sustainable solutions to addressing the structural racism and health-related social needs that are among the root causes of health disparities. So like I said, health disparities have existed for a long, long time in our communities, in our state, in our country, and Allina Health has been on a journey to eliminate health disparities in our health outcomes for a while now. There are a few key considerations that I'd like to just discuss that are critical to ensuring that a healthcare organization commits and stays committed to eliminating health disparities. So first and foremost, it's really, really key to attach health equity to key strategic initiatives within your organization. So for us, we have attached health equity to our commitment to providing safe and quality care to our patients and eliminating health disparities. It's that we have an executive sponsor, our chief medical officer, who is sort of charged with carrying that message and ensuring that health equity work is embedded into anything that we do. And then, of course, it's important to identify and prioritize your disparities. I'll go into a little more detail around that later on in the presentation. And then it's also really, really, really crucial to create an infrastructure for support and implementation of any interventions that you identify needs to be created, developed to get at the disparities. In my experience, I've kind of seen that, it's if we don't have the resources or, the infrastructure to kind of share the key learnings even internally, it is hard to continue momentum of the work. So a little bit more about data and identifying health disparities. So at Allina Health, it is standard practice for us to include the REAL filter on all our dashboards. And the REAL filter is the race, ethnicity, and language filter. And it's really a way to ensure that we have a way to drill down to the specific outcomes and experiences of our diverse patient population. You really need the data to understand the health inequities that your patients are experiencing. And one thing to note, though, is that the data tells an important part of the story, but it's only a piece of the story. It's crucial to, yes, use the data to identify the opportunities that you might have within your healthcare system or your health outcomes, but you also, just as importantly, need to ensure that you have a way to understand more of like the social factors, right? So how do you connect with the community to ensure that you understand their values and their beliefs, and how things like health-related social needs have an impact on health outcomes? So housing stability, financial concerns, and food insecurity. Those are some things that you don't necessarily see in the data, but again, the data helps you uncover the opportunities, and then you do some of that community engagement to tell the story, the rest of the story. This slide sort of highlights, very high level, the process of identifying and actually doing something about disparities. So I talked a bit about, identifying disparities with your data, right? But then the next key element or step really is understanding the root causes and then identifying solutions within our influence. So, one way to understand the root causes is to dig into the literature, look at the research that's been done around or associated with the disparities that you've uncovered, talk to the community. I can't say that enough. It is really, really crucial for us to get outside of our meeting rooms, get outside of ourselves to kind of say, okay, we've seen these disparities, but now let's talk to the patients, the communities that are experiencing the disparities, and really understand what the root cause is. And then getting into sort of prioritizing where you go from there, what interventions you develop, ensuring that you co-develop your interventions with the community. If you are deciding to do an intervention that is patient or outward focused. And then from an implementation perspective, I touched on that a little bit before, but it is really, really crucial for health equity work to be resourced well, as you can imagine, and ensure that any interventions that prove to be successful are sort of embedded into ongoing operations, and ensure that, if you have taken the time to go and engage community, seek their perspectives, and kind of show what it is that you want to do to get at the disparities, you want to make sure that in order to sort of maintain the trust, maintain the relationships, that you have the resources allocated to keep those interventions going. So I wanted to actually, going back to what I was talking about with prioritizing, right? You can imagine, at a healthcare system, the list of disparities is long. It's pretty long. But I just wanted to share some of the questions that we use to help us prioritize which measures we decide to work on. So I'll just read through a few of these, but there's one that I'd like to highlight specifically. So when you're prioritizing, you want to look at, are there solutions within our sphere of influence? So in our neighborhood with key partners that we already have relationships with. And then also, going back to the data, is the disparity statistically significant? Is it clinically significant? And then, could the solutions drive value? It's interesting when I talk about health equity work, one thing I say is, I'd like to be optimistic that, we will continue to want to do the right thing for our communities, for our underserved communities, especially with everything that's going on today. But we have to get clear on what the financial value is so that it is harder to cut the interventions that we develop. And then the one question that I wanted to really, really highlight, if you don't ask anything else, I think this one is probably the most important one, but is there meaningful impact to the community? And you could probably define impact different ways, but it's really around making sure that the interventions, the priorities that you land on are important to the community. So let me actually tell you a bit about a specific project that we did with the data that we have access to. So a couple years ago, we went through a process of assessing the disparities within our health outcomes. Again, came up with an extensive list, but started to narrow it down using the questions that I shared with you. And we landed on focusing on hospice disparities. We saw that minority patients were disproportionately dying in hospital setting versus hospice. We also saw that there was a disparity in hospice length of stay for minority groups. So this is a little confusing. You actually want a longer length of stay in hospice for patients who are eligible and are seriously ill. The reason why you want a longer length of stay is because hospice care provides comfort care and hopes to improve quality of life at the end of life. And so we don't want folks suffering for too long. And then another thing we saw is that fewer minorities were in hospice programs and in our hospice program, and there was a lower hospice referral rate amongst our minority populations. So with that, we decided to set the goal of increasing referrals to hospice for our African American patients. A little bit of background around why we decided on that goal and not necessarily the length of stay or even enrollment. We thought that it was crucial to first understand why our providers were not referring our African American patients to hospice if and when they were eligible. And really wanted to, before we engage community and kind of start on the, why aren't you getting into hospice and why don't you and this is, in explaining why the program is so great, we wanted to take a step back and look internally to see what is it that we can do within ourselves to do better. So a little bit about what the literature says. Like I mentioned earlier, we go through the process of IDing the disparity and then doing sort of that root cause analysis. And just wanted to highlight some of the things that we see in the research. So African American patients are more likely to prefer aggressive treatment than white patients. African American patients are more likely than white patients to mistrust healthcare providers. And African American prefer to care for family members till the end of their lives. So those are some key themes that we saw in the literature. And, as we were talking to some of our providers, we heard some of the same experiences from their perspective. We decided to, like I said, do that internal look and see how we can improve internally before sort of going externally to say, come to our program, why aren't you coming to our program? And so based on the research and internal data and physician feedback, we decided to start with providing some implicit bias training to our providers to sort of get at why they weren't making referrals to the patients who are eligible. So I'll spend a little bit of time sort of describing what bias is. So I'll just sort of read an official description or definition of bias from IHI and then talk a bit about it. So bias, implicit bias, also known as unconscious bias, is the bias in judgment and or behavior that results from subtle cognitive processes, such as implicit attitudes and implicit stereotypes, that often operate at a level below conscious awareness and without intentional control. So that's IHI's definition. And actually this slide comes straight from the training that we provide to the doctors. One thing that we always make sure that we mention is that we all have implicit biases. It's a human condition. Implicit biases are sort of a result of, or can be influenced by the way we were brought up, the family we grew up in, our personal experiences. But one thing to note is that those experiences can influence our actions unconsciously. So I'll talk a little bit about how implicit bias can impact patient experience and some of the consequences. So what we see in the research is that when a clinician has a pro-white implicit bias, their interactions with Black patients can look like the provider dominating the conversations with their patients, using slower speech, which can be offensive, being less positive when compared to their interactions with white patients. And from a patient perspective, they might be less involved in their decisions about care and be less satisfied with their care overall. And so these are just some of the clear examples of how bias can impact the clinical care experience. So I wanted to sort of share some of the learning objectives from our bias training. So first and foremost, we sought to provide a perspective of African American patients' perceptions of end-of-life care. So that was the slide that I went through earlier about what we see in the research. And then we explored bias, introduced it, talked about it, had very vulnerable conversations with the providers in the training, and talked about its effect on their communication, especially related to hospice services. And then we gave or provided specific resources and ways to mitigate bias and improve their communication with their patients who may be eligible for hospice. So I want to highlight, some of the key learnings and recommendations that providers walked away from the training with. So, again, understanding the intersections of culture and bias. We talked about some of their experiences with offering hospice to their patients. Some mentioned that, in their experience, they hesitate to offer hospice to their patients because of the patients, our African American patients, typically wanting to pursue more aggressive treatment. And talked about the need to, yes, hold on to that experience, but instead of having it get in the way of them offering the service to their patients and ensuring that the patients have access to hospice, use that knowledge to sort of guide and tailor the way they have the conversation to be sensitive to cultural norms. So the concept of teach back was woven into this training. This is a concept that providers are very familiar with. And we wanted to say that, yes, you may have these experiences in which African American patients don't typically want hospice, but it is critical to ensure that all patients who are eligible have enough information to make informed decisions. And so it's important to get past the uncomfortable nature of the conversation, find a way to introduce the topic, and ensure that the patient understands what you're saying. So using that teach back. And then the most critical element of all this really is to, yes, keep in mind all the experiences that you have with patients. Also keep in mind, like what we've seen in the literature, have a general understanding of cultural norms and beliefs, but it's critical to individuate your patients. Understand that the patient and family in front of you has their own unique experiences, has access to different knowledge, so it's important to sort of ensure that you are treating that patient in front of you as an individual, and ensure that you are providing the information that they need. And then lastly, recognize situations that magnify stereotyping and bias. Some of the specific ways that we sort of offer, or tactics that we offer to mitigate bias, is to sort of pause and check yourself for bias. Check your assumptions. Ensure that you're individuating your patient and that your past experiences and stereotypes are not affecting your judgment in terms of what services you offer and discuss, but ensure that you use those experiences to sort of be more sensitive. in your discussions. So I'd like to encourage anyone that is in a position to influence or do some work around health equity and health disparities to really just have the courage to do something. I had mentioned that starting with the data and uncovering the disparities is a great place to start. If you don't already have a race, ethnicity, and language filter embedded in any dashboards that you have, that's a really, really good place to start, because then you can start to see what the disparities are and have access to that type of information. So I quickly just want to show what our results for this project looks like in June 2020. We actually are still monitoring progress towards our goal to close the disparity gap in access to hospice for our African American patients. It looks good for June, but admittedly this measure sort of goes up and down from month to month, and it's expected to see that. We continue to roll out the training, and in the last few months, unfortunately, with COVID, we haven't been able to roll out more training. But with sort of a shift in focus on health equity work, we are looking at expanding our training, our implicit bias training, to be more general so that we can train providers to be more inclusive of other minority populations.
Hello, my name is Lisa Shannon. I'm Chief Operating Officer of Allina Health, and I'd like to take this opportunity to talk with you about recent events and how Allina Health is recommitting to our mission in response to the communities that we are just so privileged to serve. Allina Health's mission statement continues to serve as our North Star. We serve our communities by providing exceptional care as we prevent illness, restore health, and provide comfort to all who entrust us with their care. Never has our mission and values been more important to us than it is right now. We have to be intentional in acknowledging the senseless and tragic murder of George Floyd. It has impacted all of us. We have to acknowledge that communities of color are facing compounding tragedies, whether it be COVID at increased rates of impact or racism that exists in our communities. We must denounce racism. We must ensure that healthcare and how we serve all of our communities now and in the years to come ensures equity and care for all of our patients. We take that seriously. Safety is our core value. We have a large presence in South Minneapolis, and we are uniquely invested in the healing, recovery, and success of this community. Allina Health and Abbott Northwestern Hospital has been serving the South Minneapolis community for well over 133 years. We purposefully moved our Allina Health headquarters to Chicago and Lake more than 10 years ago. Our roots in this community are deep. We know people are hurting from the recent events and the impact of COVID-19, and we're hurting too. Yet, we are hopeful, and we are committed to a community rebuild with you. As a healthcare organization, we are committed to whole person care. We need to better understand and continue our work in the structural inequities that exist through our community. And we have a desire to grow and learn and take action to ensure that our unfailing commitment to safe care continues to address health disparities. Every day, we see and experience the generosity of people that are caring for each other and have a renewed sense of commitment and care for our communities. We've seen how you've supported us, and we commit to continuing to support you. Thank you for all that you have done to show your support to Allina Health and those that have been impacted by the recent events throughout our community. We pledge our commitment to continue to be here with you and for you. Thank you.